You will need a sterile pack, including a sterile drape, skin prep, local anaesthetic, 3 needles, 2 for drawing up and administering the anaesthetic, and 1 for the tap, sterile syringe to administer the anaesthetic, Luer lock syringe, sterile gauze, sterile gloves, some sample bottles, and if required, a portable ultrasound machine with sterile covers and acoustic gel. For this procedure, have the patient lying supine. Before you start, examine the patient using percussion of the abdomen to identify dullness. It is good practice to place an incontinence or Inco pad underneath the patient to absorb any spillages. Use the alcohol skin prep to clean the area. Clean an area larger than you will need to ensure the procedure is as aseptic as possible. You can tuck the sterile drape provided in the wound care pack underneath the patient. This gives you a bit more space to work with. Some clinicians prefer to use a sterile aperture drape to provide a more extensive sterile field. In this case, we are not dealing with tense ascites, and so it is helpful to use ultrasound to locate the fluid. Firstly, apply some sterile acoustic gel and place a sterile cover over the ultrasound probe. Scanning in the flank, at a depth of 2.2 centimeters, we can see the subcutaneous tissue. Increasing the imaging depth to 5.7 centimeters, we can see in sequence from anterior to posterior, echogenic, white, skin surface, abdominal muscle, peritoneum, free fluid containing multiple echoes, and loops of bowel moving with respiration. The needle will appear as an acoustic tip which can be followed passing through the tissues. Centimetre marks appear to the right of the image, and the ascitic fluid is lying at approximately 4 to 6 centimetres. Warn the patient about a sharp scratch, and then infiltrate the area with local anaesthetic. First a bleb at the surface, and then infiltrate the deeper tissues. Make sure to aspirate with your syringe before injecting. Use a 60 ml Luer lock syringe and a green needle. Just check first that the syringe is working. With the needle next to the probe, introduce the needle and aspirate the ascitic fluid with gentle, constant negative pressure. The colour and consistency of the fluid can give you a clue to whether it is transudative or exudative. Remove the needle, apply direct pressure with some gauze, and apply a dressing as appropriate. To finish, make sure to correctly label your samples and complete your pathology request form. It is important to ensure that ascitic fluid is sent for a cell count on admission, as spontaneous bacterial peritonitis, or SBP, can be a life-threatening complication of ascites. A neutrophil count of greater than 250 cells per cubic millimetre is diagnostic of SBP in the absence of a known perforated viscus or inflammation of intra-abdominal organs. If this is the case, appropriate antibiotics should be started. Check your trust guidelines.